Cook, and I am Advanced Heart Failure, Transplant, and Mechanical Circulatory Support, attending at University of Cincinnati, where I attend in the CVICU. And I am here with our fellow and a resident from UC, who are going to introduce themselves as we get started in this presentation.
Hi, my name is Badr Al-Hafiz. I'm a first-year cardiovascular fellow at the University of Cincinnati.
Hello, everyone. My name is Dr. Jeremy Hudson, and I am a first-year internal medicine resident here at the University of Cincinnati.
Doctors, I'm so glad to have you with me this afternoon. And so we're going to be talking today about nitroglycerin, nitroprusside, and nicardipine when the pressure is too much. This is a lecture in IV vasodilatory therapy. So before we get started, just a little bit of background. This is something that I teach on rounds all the time. So if you are going to round with us in the CVICU, I guarantee you that this will come up during your rotation. So this is a really great primer for you as we're preparing for our CVICU rotations, or just to maybe hone in some of the things that we've learned while we were in the unit. So with that, Dr. Hudson, I'll let you take off.
Yes, ma'am. So your page to the ED for Ted, who's a 75-year-old African-American male with a past medical history of severe asthma, severe depression, and moderate to severe aortic stenosis, who presents to the hospital with malaise, shortness of breath, and chest discomfort. He states that he believes his symptoms began a few hours after trying a new French restaurant with his wife, where he ate some aged cheese and mulled wine. He states that he is having some trouble with his memory since dinner. On exam, his blood pressure was noted to be an astonishing 198/160. He was taken to 120. 8 Febrile. He had a systolic ejection murmur rated 2 to 3 out of 6, with decreased breath sounds bilateral with crackles. High sensitivity troponin was elevated to 175. EKG shows non-specific ST and T wave changes diffusively. You got a chest X-ray, which shows blunting of the costophrenic angles bilaterally, along with some curly lines.
Mm-hmm.
So you and your medical student believe that this is a hypertensive emergency. Your medical student believes that this is a hypertensive emergency, and you agree. He states he doesn't know what medications to start him on, since the medical student performed a thorough medical history and found that the patient had a severe asthma exacerbation after taking some unknown medicine for his social anxiety a couple of years back. His only medication is a monoamine oxidase inhibitor that his doctor has been practicing for 40 years prescribed to him.
All right, so I guess it's good that we gave the medical student a day off today and didn't haul them in here to do this with us. I guess the first question that I'd have is, Dr. Alves, have you seen a patient like this before?
Definitely, aortic stenosis is not uncommon, and as you definitely know, comes with all comorbidities such as hypertension. I don't know if I've seen someone with severe asthma and hypertension and moderate severe aortic stenosis, but moderate to severe aortic stenosis with hypertensive emergency is very familiar, yes.
All right, so then Dr. Hudson has provided a multiple choice for you. Then what would your preference be, or what have you used in the past in patients like this?
In patients like this, especially with asthma, probably would avoid labetalol. With aortic stenosis, probably not nicardipine. Just by my experience in training the institutes I was trained at, I'd probably go with nitroglycerin as my first choice.
All right, so let's see what Dr. Hudson has prepared for us. So we're going to first talk about nitroprusside.
So in this case, I actually chose nitroprusside. Our illustrious fellow actually was completely right. With asthma, I wouldn't necessarily do labetalol, and with aortic stenosis, I wouldn't do nicardipine. Per the research that I did, I think nitroglycerin is a perfectly acceptable option. However, it's kind of used for second line, it seems like, within the literature.
You know, we can have a great debate on this, actually. So there are some pros and cons of both. And that's really what I was hoping to bring out when we had this conversation today, is the pros and cons, like in what scenario do you choose which? And so I would say that nitroglycerin definitely has its benefits because the nurses are much more used to and accustomed to titrating it. It has an easy starting dose and it's fairly well tolerated, but there are some side, kind of drawbacks to it that will come up later in this presentation that we'll discuss that makes the nitroprusside sometimes a more potent agent in certain scenarios. So, but I think we should all be competent and comfortable with both. So why don't we hear your presentation on nitroprusside, and then we'll dive into nitroglycerin, and then we'll let the medical student decide.
Okay, sounds wonderful to me.
So should I, next slide?
Yes, ma'am.
Okay.
So the effects of nitroprusside, it is used for patients who need urgent afterload reduction. Like in our case, where this patient has a blood pressure of 198 systolically. Also, if they were to have mitral or aortic regurgitations. Unlike most nitrates, this kind of nitroprusside causes a balance of atrial and venous dilation. So if you were to see our pressure volume curve, with the control, our patient would be in a gray area where they have extremely elevated pressures. Nitroprusside would shift them over to the left by decreasing that afterload.
One thing I really like about this pressure volume loop is that you can really get a strong sense of, even though the blood pressure is lower. So if you see on the y-axis, you see that the blood pressure is lower, but the stroke volume is higher. Can you see what I mean by that?
Yes, ma'am.
Yes. Yeah. The width of the loop is what represents the stroke volume. It gets wider, although it's all shifts to the left side of the graph, which is the good side of it.
Right. And so like at the same heart rate, at a greater stroke volume, you'll have a greater cardiac output, even though the blood pressure is lower. And so this is a really nice demonstration by the pressure volume loops. So some people might not be as familiar with the dosing of nitroprusside. So why don't you run it down for us?
So the dose is usually about 0.5 micrograms a minute. Usually you increase it about every 5 minutes as tolerated, to a dose range of 3 micrograms per minute per the research.
And it comes on and off pretty quickly. And so sometimes we use nitroprusside for challenge studies in patients with pulmonary hypertension that we think is, due to their left-sided, elevated filling pressures, because you can really drop those left-sided filling pressures and see what transpoint gradient remains. And so nitroprusside, because it's quick acting, is good for something like that. But there are some warnings. So you want to take us through?
There are. On the beginning of this the slides with nitroprusside, you will see that it has a lot of carbon bonded to nitrogen, and those can easily break off and form cyanide, which is very, very, very toxic to the human body in most life forms. Also, nitroprusside requires close and continuous pressure monitoring, usually with an intra-arterial catheter, in order just to measure the pressures. It can also cause reflex tachycardia, and when it stops, it can cause rebound vasoconstriction. There is one additional contraindication, but before I was able to tell my medical student, I was paged again.
Yeah, and while you're running to answer that page, one of the things I wanted to add with this is that you can see that if an arterial line is required for nitroprusside, that could lead to a delay in using it, or at least using it safely. And so here's a situation where you might start or hang nitroglycerin to get an A line, or if you wanted to avoid an A line in someone, you could use nitroglycerin. So you're paged again for the next case.
Yes. So this is Dan, who's actually the brother of our first patient. He is a twin brother. He is a 75-year-old African-American male with a past medical history of significant tobacco history, chronic kidney disease stage 3B, ischemic cardiomyopathy, NYHA class 2A with an EF around 35%, who presented to the hospital with shortness of breath that has been acutely worsened over the past week. On his vitals, his blood pressure was 120/70, a MAP of 87. Heart rate was 95. He was afebrile, but sat in 95% on room air. You did hear a third heart sound with bilateral pulmonary crackles heard in the mid-lobes bilaterally with decreased breath sounds. When you go to feel his fingers, you do feel like cold extremities. Labs were remarkable for elevated NT, pro-BNP, and BNP that was elevated. Tropes, however, were within normal ranges. BUN and creatinine was elevated, suggestive of a acute kidney injury, along with lactate being elevated. You got an EKG, which shows non-specific diffuse T wave changes. You also got an X-ray on him that shows blunting of the causal-phrenic angles bilaterally, along with curly lines and peribronchial edema. You was present your echo for that night, and you revealed to you a diffuse left atrial with lateral wall hypokinesis of the left ventricle.
All right.
So the medical student believed that he was much sicker than his brother, and you tend to agree. The medical student, who was very astute and interested in cardiology, they diagnosed the patient with acute decompensated heart failure presented with tissue hypoperfusion due to increased mean arterial pressure. For management, he stated that he wanted the patient to go to the cardiovascular ICU, start him on diuretics and nitroprusside to help with fluid flow. I was about to press the order to have him start nitroprusside, but luckily our fellow who's with us stopped me and says a certain word about why I shouldn't start nitroprusside on this patient.
Because patients like this, especially with AKI on CKD, you have much higher risk of cyanide toxicity.
Absolutely. And actually, the cyanide toxicity is really a challenge at the University of Cincinnati because our cyanide test is a send out. And so although we can do cyanide levels, it takes 3 days to get the result back. And so some institutions, maybe the institution that you're watching from is able to get cyanide tests on a daily basis. And in that case, you might be able to press it, in a little bit lower GFR, but typically we stay away when there's acute renal failure using nitroprusside for that reason. So that's a good team effort with the medical student and the resident and the fellow. Very good. We covered that. All right. So we have this patient, and this is kind of, we didn't plan for this question, but I'd ask the medical student, and either of you could help the medical student with this PIMP question. One of the things I find interesting about this patient is if I think about them in the classic 4 quadrants of heart failure, he fits into an interesting quadrant, right? So
Yes.
the 4 quadrants, the wet and dry, warm and cold. So what quadrant did this patient fit into?
So if you were to visualize the box with the top left corner being both dry and warm, on the right side would be cool, and on the bottom would be wet. He will be in the far bottom right, where he'll be wet and cool, due to the hypoperfusion and the edema that you hear. The curly B lines are showing pulmonary edema.
So inarguably, this patient's congested, and has his volume up. One of the things that's interesting about this patient is that a lot of times if I gave the assignment of presenting a patient in cardiogenic shock, they would look maybe a little different than this because they would be hypotense, right? And so one thing that's really interesting about this patient, and the reason why this comes up here, is that the patient's not hypotense. Now, the first patient you presented is hypertensive with a systolic blood pressure of 190. This one has a systolic blood pressure of 120, but that looks like hypertension for a heart failure doctor.
Yes, ma'am.
Because we don't see pressures like that before. So our patient, let's go back. What was the mean arterial pressure? 87.
87.
Yeah. So that's somebody who has plenty of blood pressure. And so because we have a separate talk on how to use inotropes in patients in cardiogenic shock, but this patient is different because this patient has plenty of blood pressure despite the fact there's hypoperfusion. But how does that happen? How is there plenty of blood pressure but no peripheral perfusion? What's out of whack?
Oh, goodness gracious. If I'm not mistaken, it would be just due to overly constriction of his blood vessels.
Absolutely. Yep. It was on the tip of your tongue, wasn't it, Vader? It was the SVR. Yeah. So it's a high SVR state. All right. So we're back to our IV vasodilators because it's going to affect the SVR in this patient. And so our choices are nitroprusside, nitroglycerin, nicardipine, labetalol. And so nitroglycerin as an option. Do you want to tell us more about nitroglycerin?
Yes. So nitroglycerin is also a nitrate, just like nitroprusside. The reason why I didn't want it, labetalol wouldn't be quite the correct choice is because the patient seems like he was in cardiogenic shock. Like we said, like Dr. Cook perfectly said, that he is in the wet and cold stage of heart failure. It's also faster to titrate on with nicardipine. And also because this patient has AKI, we can't use nitroprusside. And a lot of nurses, I think, at our institution are more comfortable with titrating it. The effects of nitroglycerin, just like I said, is a nitrite. It's used mostly for cardiogenic shock in order to reduce the preload and decrease the myocardial wall tension and improve myocardial perfusion. Just to take off some of the workload of the heart, so to speak.
Absolutely.
So these are the doses that we usually typically see is around 5 to 10 micrograms per minute. Usually increase about that same amount about every 3 to 5 minutes as required or tolerated up to a max of about 200 micrograms a minute. Now there are some warnings. You can easily develop a tolerance to nitroglycerin within like the first day or two that you're on, according to the literature I read. And it also can cause hypotension if used with other PDE inhibitors like sildenafil.
All right, so back to our patient.
So 24 hours later, you're back in the CVICU with your medical student. And unfortunately, your Starbucks that you just received spilled all over your sign out. The nurse paged you about the patient, Dan. She's noticed that he has curiously had urinated about 2.5 liters while getting about the same amount in terms of IV fluid. She knows that the blood pressure has continued to increase despite her titrating the nitroglycerin up and up and up to its maximum rate. And before you could log into your EMR, in our case Epic, and check the handout, it undergoes its monthly maintenance. And there's actually what to
do. So what would you like to do? What would you like to do? So what this is bringing out is the other sometimes, difficulty using nitroglycerin. So you mentioned in the warnings that the nitroglycerin patients can become tachyphylactic to it. So you need higher, micrograms per minute in order to maintain the same amount of unloading. But the other problem that happens, and I would just, have to know this being a heart failure doctor and looking at every single cc of urine, 10 cc's at a time, that there's a lot of volume associated with it. And so the patient got 2.5 liters of nitroglycerin and got diuresed 2.5 liters, and we've made no progress with the congestion.
Okay. Oh, excellent. I didn't realize that. In this case,
so what medication do you want to switch them to?
The last one we have on our checklist is nicardipine. It is a calcium channel blocker, and its uses include cardiogenic shock, ischemic stroke, acute or aortic dissection, and hypertension. We usually start this in, I think here we started about 1 to 2.5 milligrams an hour and titrate that one up to about a maximum of 5 milligrams an hour. It has a similar blood pressure lowering effect to nitroprusside. However, just like Dr. Cook says, it does have a slower onset and its half-life is a longer. And it does have those same contraindications where you can't really use it in aortic stenosis or if you were to have HOCM or hypertrophic cardiomyopathy.
That's terrific. Well, I really appreciate you putting this slide deck together for us for teaching today. And I appreciate, Vader, you joining us to put in a fellow's point of view. I think that, really the driving home points are that you've got, if you have a patient who has heart failure and plenty of blood pressure and decompensated heart failure, you want to use afterload reduction because the SVR is too high. Nitroglycerin is really our mainstay in this situation, but we have a drawback that it's a lot of volume and that patients can become tachyphylaxis on it. Nitroprusside is a good option for people who don't have renal failure, and it also works really quickly, but you need an A line. And for patients that have renal failure that you need to use IV vasodilation, you could use nicardipine. But typically, nicardipine is not our first option because it's a little bit more difficult to use and that it has a longer half-life.
Yes, ma'am. Well, thank y'all so very much for allowing me to come up with this slide so we can teach fellow medical residents and fellows.
And I tell you, you guys won't be first-year fellows and first-year for very long.
No, ma'am.
All right. We'll see you all later. Thanks so much for tuning in.